just is. It does exactly what I said. Keeps your muscles healthy, less strain on the heart. Heart doesn't have to use as much oxygen. Even if you have blockages, it actually treats the heart muscle. Okay. So that's sort of my start into this. You know, this is meant to be sort of a throw it out there. What do you got? You know, I know a guy that has a sick heart. You have a sick heart. You don't have a sick heart. How do I keep my heart healthy? You know, should I eat more turnips? Anything. I don't know. I would eat less turnips. So, in general, so. Brussels sprouts. So I don't know if there's any questions. I can talk all night long, and I will if we, you know, but sure.
So does the exercise help the heart? Helps the heart muscle? Does it also help with regression of the blockage?
So that's a very interesting concept, is regression of coronary disease. And the problem we have with regression is that the classic literature out there was Dean Ornish, the Dean Ornish diet. You guys familiar with it? If it tastes good, spit it out. It's cardboard, just eat cardboard and you'll be okay. And do that for the rest of your life. And you'll live a long, happy life, except you might not. So have a miserable life and just eat cardboard. So that's the Dean Ornish. And the nice thing about it, I mean, it was a great diet, a very Mediterranean diet, still around, and there's Dean Ornish Center still around, with exercise. It's not just the diet. But the issue was when they looked at progression of disease versus regression of disease, they basically were looking down the corners and saying, yes, with the Dean Ornish diet, we caused regression. Okay? So we could actually reduce the plaque burden with that diet. The problem is, if you looked at deep into the statistics, the right coronary artery might get worse, but the two on the left got better, so statistically you got better. So you had one artery that actually needed to be treated down the road, but two other ones got better. So it's very hard when you look at these trials, exercise, to really say that regression is across the board, across lesions. We don't understand why certain blockages get angry, other ones don't. I always tell people that, you know, when they come to us, it's kind of like going to a dentist. You know, sometimes you need something done, sometimes you don't, and it's nothing that you're doing wrong, you're doing everything the right way, but we can't predict how a blockage that's 50% today can turn into a heart attack tonight with that rupture that I talked about. So in general, there are exercise trials that have shown regression. There are diet trials with exercise that have shown regression. How you measure regression in an individual patient is easy, but across 1,000 patients in a trial where it says, yeah, we can show regression, but a third of the lesions actually got worse, 2/3 got better, and we got statistical evidence that says we can regress lesions. That's the problem, is that it's very lesion dependent. And so, but in general, yes, exercise can do that too. Yes?
Talk to us about statins, particularly the risk versus benefits.
Oh, you just start me up now.
Oh, let me finish, because I really have a question about, is there
Go
a
ahead.
time when they've had enough? Like, you know, in older age. Like, and if so, what age?
Okay, so people think I'm crazy when I have a 9-year-old that comes in with a heart attack and I put him on a statin, okay? They think, what are you doing? This is 90 years of damage. What are you doing? Remember I talked about inflammation in the walls of the vessels. And I'm not going to go on a statin rampage. I'm just going to give you my spiel on statins, and I'll show you something I think is kind of interesting. Statins, in general, half of what they do is prevent your liver from making too much cholesterol. Okay, that's how they were thought to work initially. They're the most potent things for reducing cholesterol, the bad cholesterol. There's side effects to statins. We talk about that. There's issues with, you know, cost isn't as much of an issue, nearly as much of an issue as it used to be with the statins. But statins basically do another thing, and they reduce those white blood cells from causing inflammation. They reduce plaque rupture. Two types of heart attacks that we see. One is a progressive narrowing, okay, and then you form a blood clot on it. One is somebody who says, I was just in your office last week, I had a normal stress test, I had a normal EKG, how could I have had a heart attack a week later? Because nothing showed up because you had a 50% blockage. That 50% blockage had a very thin capsule on top of the plaque that was there. The inflammation ruptured the plaque. Now you had the big heart attack. Statins reduce inflammation, stabilize plaque. Can reduce progression of plaque, can actually decrease the size of the plaque. But again, some plaques get bigger, some plaques get less. I'm not saying statins are the only answer. But statins reduce inflammation, and we've seen in, not just here, but across the country, that the number of what are called STEMIs, the big heart attacks, I just closed off a vessel in the ER having a big one, have been reduced. Much more dramatically than we would have expected from just general care. And people are getting older, we're treating older patients. And most people think it's because of statins, early statin use for cholesterol, which prevents the big heart attack. Okay? We can talk about the bad side of statins in a second, but just bear with me for 1 minute, and this will kind of tell you what the deal is on the statins. So every time a clinical trial has been done in the past where people used statins versus placebo, you can imagine the patients that were, if this is cholesterol over here, over time, patients on drug did that, okay? Cholesterol went down, okay? Patients on placebo, where do you think that went? Wow, went down. Why did it go down? You're motivated, you're in a trial, you're exercising more, you think you're on the right drug, you're on a placebo, you have no idea. So this is the problem with clinical trials, is you have people now that are altering the outcomes. The placebo has nothing to do with that. It's because you're motivated, you're in a clinical trial. That's who goes into trials, goes every 3 months to see somebody, gets their blood drawn, stays in it for 3 years, Framingham trial. Some of these patients have been in 20, 30, 40 years, getting their blood drawn, doing all this. So they started measuring something called a C-reactive protein. And C-reactive protein is a measure of inflammation in the body. And as long as you don't have a urinary tract infection, gout, something else going on that's causing inflammation, it's a pretty good judge of what's going on inside the arteries, okay? So what they did was they measured CRP. I'll just do that in a different time. So CRP, if you were on treatment, as you can imagine, CRP went down, okay? This is because statins reduce inflammation in the walls of the vessels. What happened in the patients that their cholesterol still went down, that weren't on a statin? CRPs went like that. So over 3 years, you started seeing more inflammation in the walls of the vessels. You were still putting cholesterol into the walls of the vessels despite the number going down. So it's not all about the numbers. It's about how you deal with the cholesterol that you have. And if the cholesterol is there and you can reduce the chances of it causing a problem inside the wall of the vessel, your event rates go down, your cholesterol goes down. So this was a very, very interesting finding. Initially was something called Pravachol or Pravastatin. It was one of the first statins out there. Mevacor, Pravachol was close behind that. Zocor, they all came out roughly the same time. Mevacor was the first one. So it's just telling you that no matter what I'm doing to lower cholesterol, and again, you can use your garlic, your red yeast rice, you can use anything to lower cholesterol. It doesn't mean you're preventing progression of disease. You have a number that you're looking at, not necessarily what's going on. So, sir?
So in these studies, the placebo group, with their CRP going up, did they show a greater incidence of heart attacks?
So what happened with these trials is that, yes, over time, if you were on a statin versus no statin, you reduced your event rate. And most of the trials were like 5-year trials. Okay? The issue was when they went back to look at these orange lines was after the trial was over, they saved the blood from these people and basically spun the blood back down and said, hey, now we have a new test, let's look and see what actually happened. That's what was intriguing about this, was to say it all made sense in the fact that these people actually did better on statins. Does everybody need to be on a statin? I'm not suggesting that. But the data is very clear what statins do and why you should be on a statin. Now, I'm not real happy about what happened a year and a half ago or so with the new guidelines for cholesterol, okay? So we're all used to measuring cholesterol and LDLs and where we should get our levels, and if you didn't have significant risk factors, you wanted your LDL, your bad cholesterol, 130 or less, but we wouldn't treat until it was 160. It's hard for somebody to walk in my office with an LDL of 160 that I don't want to treat. But you have to step back and say, why is the patient here? Most of my patients are secondary prevention. They already had a problem. So I'm on a whole different boat than the primary care physicians, where they're trying to figure out who to use statins and who not to use them in. So what happened was, then it was, we want the LDL less than 100 if you have heart disease. And then if you're diabetic, now we want less than 70. So there's this whole push to ramp up the statins to get your levels down to below 70. In the midst of that, now they've come out with new guidelines that say, we don't really care about the absolute number. You know, if you were this person with these risk factors, we want you to reduce your LDL by 50%. Well, I'm in a place where I have no idea where people started. They're already on statins. I don't even know where to go with that. If your LDL is 100, was that half of what it was 3 years ago? I don't know. I have no idea. And maybe we didn't even measure 3 years ago. You know, you got to put on a statin. So I think that it's very short-sighted. Now, it's easy for me because if you have heart disease, you need to be on the highest dose statin of either Lipitor or Crestor. So they made it simple for me. It's not so simple. You know, people don't tolerate the highest doses of the statins. They get side effects from them. And they were teaching us 3 or 4 or 5 years ago that going from 40 to 80 of Lipitor, you were doing a minuscule amount to reduce cholesterol, so why do it? You're just getting more side effects. Now they're saying everybody should be on 80 to start. So I don't buy that. I'm sort of in between with the numbers and with the dosing and who needs statins. The AHA, American Heart Association, American College of Cardiology still say if you have coronary disease, we don't care where your cholesterol levels are, you should be on high-dose statin. That's the national recommendation. Is it right? I don't know. But that's the national recommendation.
What's your opinion of the difference between measuring absolute numbers, total cholesterol, LDL, HDL, versus ratios?
So there's a couple things there. Ratios, when you start looking at good cholesterol, bad cholesterol, so you're looking at HDL, LDL cholesterol ratios, total cholesterol, there's something called, well, let me back up a second. There's actually a blood test that can be done now. It's called a vertical profile, or a VAP, that's done. It actually looks at all your different particles to figure out whether or not your HDL level, which is 60, which is awesome, is actually good HDL. Because some of that HDL might not be so good. And so when I've used the VAP profile, and again, I don't use it often because I'm already treating people that had heart attacks. It's a little different look than somebody who's never had a heart problem before. But when you start looking at that VAP, you start seeing, wow, I thought that HDL was actually protective, and it's not. So when you start looking at ratios, you're assuming that your good and your bad are what they're supposed to be. Sometimes the bad ain't so bad, and the good ain't so good. So the ratio doesn't really matter. So I'm not trying to confuse things here, but I'm just saying that in a general population, looking at a 50,000 patient trial, ratios are helpful, but in an individual, when you start looking at the minute details of what your cholesterol profile is, and the reason I say that is because certain drugs, if you start looking at little particles, APO little a, and some of the other things that have come out, are not treated with the statins. The statins don't work on them. Okay, they will lower your LDL level, but they don't treat those things. Exercise, niacin, which is hit the pendulum the other way, don't use it, doesn't work.
It works.
No, I know it works. But what I'm saying is, in the general population, if you're just trying to raise HDL with niacin, it doesn't necessarily cause statistical significance, so everybody says it doesn't work. Well, in the individual that has low, or high ApoA, it's going to reduce that, and in specialty care for that individual, it may make a difference. So it's a long-winded answer to, should everybody get a VAP? I don't know. I mean, if you have coronary disease, yes, we're going to treat you with a statin anyway. Is there something else sitting there if you're 40 years old and you had an MI? Yeah, I'm going to start looking at other things. And it's just a one-time test. And insurance pays for it. You get it one time, you know where you're sitting and whether or not you have effective HDL particles and LDL particles. Now they're looking at, I just saw something that came out last week too, that looking at HDL and breaking it down, if it's holding on to really heavy, bad stuff, it can't do its job. So you're still measuring HDL, but it's all loaded down with junk, and I can't get rid of it. So now there's a whole other move in looking at what the HDL is already loaded at. HDL, the good cholesterol, is at least simplistically, takes the bad cholesterol out of the walls of the vessels and takes it to the liver and gets rid of it. But HDL is a very complex molecule. There's some good, there's some bad, there's overloaded. This whole garbage truck, it ran out of gas, I can't get rid of it. Or I don't have a dump to put it in, essentially. So it's very, very complicated cholesterol stuff. And I think if you're a younger patient, family histories, things like that, that VAP is a very important thing for us to try to figure out, are we doing the right thing with not treating you with things like niacin. So. Somebody else, somebody had a hand up over here. Yes, sir.
So you talk about moderate exercise. Can you define that in terms of heart rate? I mean, it's a very easy thing to do today, right? You can get an app on your smartphone,
Yeah.
You can follow your heart rate. If you walk slowly and your heart rate never goes up, if you really exercise.
Yeah, so the trial that I was speaking of is it's a little complicated, and I actually I had it sitting in my car because I wanted to bring it in to actually show you specifically, because I knew you would be thinking about this. No, I'm just saying, because of levels of exercise. And the way they broke it down was either hours per week that you exercise, the level that you actually exercise, and these were runners, these were joggers, slow joggers, medium joggers, fast joggers, and then it defined it into, did you do your jogging strenuously? So did you do it in moderately? So I only jogged a half an hour today, but I sprinted the whole time. Those were the people that tended to do the worst. The sprinters, really going at it, and then 4 hours a week, 5 hours a week of really strenuous activity. The 2.5 hours a week at moderate to mild, and we're talking about jogging again, but and they didn't talk about heart rates, I'll be honest with you, with that particular trial. Just in general, you guys probably know this, but 220 minus your age, if I put you on a treadmill and you could do a treadmill, 220 minus your age is the fastest your heart could ever get to, okay, with strenuous activity, 220 minus your age. So then when we look at a stress test, we want 85% of that 220 minus your age is what we're looking for to say that is a maximal stress test, to say it's a good stress test. Now we know that we're seeing the whole heart. People that exercise, we don't want them at 85%. You're not going to last there very long. You achieve what's called your aerobic threshold or anaerobic threshold, where all of a sudden your muscles are creating lactic acid, you're cramping up, you vasodilate, your blood pressure drops, you feel like crap, you pass out. You don't like that, especially on a stress test. But that's why people that run marathons and half marathons and things that they haven't trained for, why they just fall apart even 50 feet from the finish line, because they've reached that level where their muscle just can't do it anymore and their blood pressure drops out. So your question's a good one. I'm not trying to skirt around the idea of what is good exercise. I don't even know the answer. I still think 20 to 30 minutes of getting your heart rate up to 60%, 70% of your maximum predicted, consistent. People are all about weight loss, looking at these interval training and go fast and slow down, and go fast and slow down. I have no idea. Yeah,